Dr. Brett Ruffo, he is a board-certified colorectal surgeon. We're going to be talking about the topic of colorectal cancer. This month of March is National Colorectal Cancer Awareness Month. Dr. Ruffo is affiliated with Peconic Bay Medical Center on the island. It's nice to have you join us on our program, first of all.
Thank you very much. Good morning.
And welcome to the Fan.
Thanks.
You know, I say the month of March, having that affiliation or designation of Colorectal Cancer Awareness Month, how important is it to recognize colorectal cancer in that way? Because, again, I always think you say that topic to people whose lives have not been touched by this in some fashion, and their reaction may be a pause or that look like, I don't want to talk about that.
Well, that's certainly a conversation that I'm not sure many people just put right out there on the table. But unfortunately, colorectal cancer is, the number 2 cancer killer in the country. So it's something we have to focus our education on, and having a month to really explain to people, patients, potential patients, or just anybody, some education on the importance of screening, or just simply to get people to be more aware of the power, the power of screening and what they really need to understand about the disease.
When you say that statistic about, colorectal cancer having that designation, what's the reaction that you get when you say that usually?
Surprised, always. I usually use an example in my office, and I say, I'm sure you probably understand or know more about pancreatic cancer than you do about colorectal cancer. And the answer to that is, of course, from either movie stars or just the just seems the attention that it gets. They're very surprised at colorectal cancer.
Why do you think that is?
That's such a great question. It's really hard to know. I just think we have to begin educating patients more. Colonoscopy has been around for certainly a long time, so has other screening modalities. Why it's not more in the forefront, I'm not sure. My guess would be I think it's the embarrassment factor. That's what I think. I think it's just a topic that very few people want to just have on any forum. It takes a little bit of time and patience and just willingness to talk about it.
All right. Hopefully we can help some people today perhaps take a step or two in getting past that, because having the discussion is an important one to start, hopefully, some proactive movements as well. When we talk about colorectal cancer, I also have to mention, for the benefit of the people who are listening to our discussion today, that you had the experience in your lifetime where you had a family member who died from colon cancer. This was your father, as I understand.
He died of rectal cancer when I was an intern at my surgical residency program in 2002. Miserably. And he was really just a typical type of patient that you see, very nervous, had a little blood in the stool, didn't want to talk about it, didn't want anybody. And I would obviously say he had a few choice words that certainly is not going to be helpful to the conversation, but I think it was very much a dignity factor for him, and unfortunately, it took his life.
In the period of time leading up to his diagnosis, how long had he been exhibiting symptoms, or do you know? I know the surgeon who operated on him, so obviously I have a little more information than some people may have about their family members. I think he had it for a very long time. There was also an insurance issue, which is something I probably haven't mentioned much. He didn't have insurance at that time, so that was also part of the issue, to go to the doctor and get a diagnosis. And at that time, there were very specific rules for insurance companies and who would be covered, who wouldn't be covered if certain diagnoses were there before he had the insurance in place. So that also played a huge factor in his disease. Has that changed? I think in some respects it has, and some it hasn't. I got to be honest with you. I'm not sure of the rules and regulations of every insurance company, but it certainly was then. So I think he had symptoms for a very, very long time, probably at least a year, at least.
And why, if you don't mind my asking, because some of the people who are listening to our discussion today may wonder, for you yourself, what is this like talking about this? And why do you talk about it? Because I think I know, but perhaps you can explain this to our listeners.
Well, I'm not a very open person about my life, but when it comes to things about, because this affects so many people, I think, and when you have someone who does this for a living and you have such a close experience, so yeah, I understand the disease and I know how to treat the disease, but I also know the experience of when it goes bad. And you see somebody who goes from a healthy individual to really completely destroyed by a disease that really, most likely, and I can't say guaranteed, simple screening would have really prevented a significant illness. And when next year we're posed to having 150,000 new cases, I definitely think we need to address this.
150,000 new cases in this country.
That's right. 100,000 colon cancers, over 40,000 rectal.
I didn't ask earlier in our discussion, and again, I always in my mind kind of make an assumption that maybe I should not make. When we're talking about colorectal cancer, can you, and I realize this is kind of a delicate area because we are on broadcast airwaves, talk about that area of the body in terms of how cancer manifests itself there. Because, we're lay people, okay? We don't see and deal with what you deal with basically on a daily basis, I'm assuming.
I think what's funny is, like I said, I told you earlier, I did construction my whole life, so I try to think of analogies that kind of make sense. And I think of it like plumbing. All the plumbing's connected, but they're all different treatments. The colon, the rectum, the anus, the treatment modalities are different, and you need to understand the differences. I think when we talk about cancer manifesting itself, there's a whole slew of different reports of if the right side of the colon, which is closer to the small intestine, or the left side, which is closer to the anus, that they do have different symptoms and so forth, which is true, and that's a whole nother conversation. But unfortunately, cancer doesn't normally give you symptoms until it's a problem. It's not always, but that's the biggest issue, that's the whole purpose of screening, is to get you before you have symptoms. It's an asymptomatic patient who doesn't have disease or doesn't think they have disease. It's not somebody that comes in bleeding with symptoms.
And when you're talking about the colon itself, how long, how big an area are we talking about?
The colon's it's roughly 4 feet, roughly.
Okay.
The rectum's about 12 to 15 centimeters.
Okay.
The anus, that's always argued by the surgeons versus the pathologists, but that's only a few centimeters in length. So the colon is obviously the longest of the plumbing tube, and the rectum is about 12 centimeters.
And when you talk about the incidence of colorectal cancer, as you said that, I'm thinking, and I'm sure some of the people who are listening to us are thinking, all right, well, if I am related to someone who has this, what's the chance of me getting it?
It's an extremely high risk. There's a lot of different numbers out there, and that's why I try not to quote statistics too often, but something like an 8-fold increased risk. But the thing is more that I think that's the number one risk factor. There are some other exceptions, but I think that's probably one of the most important risk factors that you can discuss. And again, there's always some literature or some data that could say one versus another, or if you talk about more complicated diseases. But I think for the average person discussing screening without other disease processes, I think family history is probably one of the most important risk factors to understand.
And that family history, does that have to be someone, is it one generation to the next that we're talking?
It's an interesting question. This certainly leads into some genetic dispositions to colon cancer, which we are trying to be more aggressive at screening for some genetic factors that may link us to earlier colon cancers. There's a syndrome called Lynch syndrome, but it only accounts for 5% of all the cases. Not, I shouldn't say only, but it's a much smaller number than the average cases you're going to get. But it can skip generations, but if it's in successive generations, your index of suspicion as a surgeon or any medical profession dealing with this, it has to raise your level of suspicion to either screen earlier or order some testing. There is some genetic testing out there for some of those patients as well.
Well, I think what we'll do is, I wasn't going to do this earlier in our discussion, but I think this will dovetail perfectly with some of the areas where I want to go in our discussion. Let's see if we can as well work in some thoughts from some of the people who are listening to us, if they're on point with some of the issues that we are raising. WFAN's toll-free line is 877-337-6666. It's brought to you by Mohegan Sun. Create your moment at mohegansun.com. Time to shine. Well, as we are talking with Dr. Brett Ruffo on our program this Sunday morning, let's go to the phone. We'll go to Princeton, New Jersey, to Keith, who's been holding for some time. Keith, good morning. Welcome to the Fan.
Good morning, gentlemen. Thanks for taking my call. I really appreciate it. And I got to tell you, Dr. Brett, I've been an OR technologist for 20 years, and I've worked in general surgery for a majority of those years. And what really breaks my heart is I know how hard you guys work, and I know the hours that you put in, and I know how each and every patient is so sacred and so special to you, and everything that the surgeons deal with is all about preventive medicine. And if I could tell the listeners one thing out there, is that no matter what you go through, no matter what you feel, or no matter how your reaction might be, my father passed away from pancreatic cancer, and I know his reaction was sort of like, it's no big deal, it's no big deal. And then when he finally went to the doctor, it was too late. But I tell you, everybody out there who's listening, please, if there's even the slightest bit of hint and on your part, please don't hesitate and go to the doctor. But as somebody who stood next to surgeons for 20 years, I can certainly tell you that they work so hard. And thank you for taking my call.
Thank you for your call this morning and for being patient on the phone there, Keith.
He brings up a very good point. The preventative, I think surgeons sometimes, as a surgeon, I think people think when they walk into your office, you just have a huge knife just waiting to go after them as a surgeon. But the reality is that being a surgeon, I would certainly rather a polyp be removed from a patient, whether I did a colonoscopy or a gastroenterologist or so forth, than remove a cancer from somebody. I think patients need to understand that the surgeons, as well as the medical doctors, I think we are really trying to focus more on preventative care and not putting more people in the operating room.
We are in studio with Dr. Brett Ruffo on our program. Dr. Ruffo is a board-certified colorectal surgeon. He's affiliated with Peconic Bay Medical Center. Now, where is Peconic Bay, by the way?
Pretty east. It's between the two forks, all the way out east off the LIE. If you take the LIE to the end, Long Island Expressway to the end of it, that's where it is. But it's a much busier town than it gets credit for.
Way, way out there.
Yeah, well, we need good hospitals out there too.
Of course you do. When you're talking about the topic of colorectal cancer and talking about the idea of treatment and approaches to treatment, how is that changing?
Boy, that's a loaded question.
Because the reason why I asked that question in that fashion, let me just preface this, is based on something you said before we paused for our update about the fact that even though you are a colorectal surgeon, you and your colleagues in many cases are trying to get people more oriented toward the idea of prevention.
Absolutely. Some of the ways we use the treatment modalities have changed. Like colon cancer is treated much differently than rectal cancer, depending on the situation. Mm-hmm. Anal cancer is treated differently than that. So I think those conversations are certainly, and we could certainly go over those. But the idea of preventative health is to get these things, or to get any potential precancerous lesion out of a patient long before they have to have this discussion regarding what the treatments are, because every individual case is different. The most important thing to understand is, and I guess it's very simple at heart, is the earlier any of us get to you, or any patient that potentially has this disease, the better the outcome.
And when we're talking about detection, what is, or what has proven to be most effective in detection?
What another great question, in a sense that it's very difficult to answer, because, believe it or not, a lot of the data on screening is not very good.
if you really break it apart. We do know that some of the stool blood tests that we did, which are changing, which are really significantly changing how we test the stool for blood, which kits we're using, what we're trying to identify to be more effective at these screening modalities. That's really been the only proven test to decrease mortality from colon cancer was the stool blood test. Colonoscopy, there is some data out there now trying to finally prove once and for all that colonoscopy will diminish the incidence and or increase the overall survival with colon cancer. But that data is actually still in progress. True, effective, good literature, so to speak. But we do feel that colonoscopy most likely is the best preventative tool that we have.
All right. Now for the $64,000 question here. Why is it that so many people don't take the proactive approach here?
I don't really know the answer because everybody's personality is a little bit different in the sense that if someone tells you, look, the number 2 cancer killer in the world is colorectal cancer, and gives you some of these numbers, I understand the fear of a bowel preparation. I understand the fear of showing some pretty personal body parts to people or having some instrumentation of these very private places. But unfortunately, sometimes pride doesn't necessarily help you, and some of us have some personal issues like we talked about earlier. So I think we just have to. I think the education's more important because that will lead to more patients just saying, "Fine, just let me just get this out of the way," because the risks are pretty small. They are there, but they're pretty small, and this is a very well tolerated procedure. And I think that the more people understand, hopefully the more people that will be screened, because that's going to really change our data, is when we finally get to the point where the appropriate number of people are screened. Now you have some real legitimate data. Doing a colonoscopy on somebody who's 60 years old with symptoms doesn't necessarily say you have a good screening tool.
Well, in the ideal situation, when should screenings start taking place?
For a colonoscopy, the standard of care in this country is 50 years old. That's the standard, by 50, without factoring in risk factors or some other issues or some other illnesses that would prompt us to do an earlier screening. But 50 years old currently is the standard in this country.
Okay, and how often does that procedure need to then be done? I mean, it's not just a one-time thing, obviously.
Again, putting all if you just a person who has a colonoscopy without any other risk factors, if that colonoscopy is normal, the standard says 10 years later should be the next colonoscopy. Most of us don't really feel that that's a legitimate follow-up because, unfortunately, there is some incidence of missed polyps, these kind of things. So I think the follow-up needs to be shortened a little bit. But based on the data, based on the standard of care right now, the recommendation would be 10 years after your initial colonoscopy. But personally, I think that's too long.
What would you think would be more appropriate?
I think 5 to 7 years is a reasonable follow-up. I do. I think that's much more appropriate. I think in the rare case that if you miss a polyp or if you miss something small in there that you could have removed at that time, I think 10 years is just too long to sit and wait on that, especially when there are some reports that 12 to 15% of the time we may miss small polyps. So I think that 5 to 7 years is a little more appropriate. That's my opinion, though.
And for someone who has risk factors?
If a person has colon cancer in a first-degree relative, the recommendation is 10 years. Once that person, so if the person was diagnosed at 55, you should have your colonoscopy by 45. If the person was diagnosed in their 40s, at least by the time the patient's 40 years old, they should have their first screening colonoscopy. But there are also some people that argue 40 should be the screening.
And the other thing that I don't think we touched upon in terms of people who are most at risk or most susceptible, are there specific ethnic groups who would be more susceptible to colon cancer?
Not necessarily ethnic groups. I think some people used to think that maybe whites versus African Americans versus this were more affected. But what we found is that if you really analyze who's getting instances where the incidence of colorectal cancer exists, it's pretty even.
And men and women, it's not much different. We know that even in women and or men, it's the number 2 killer. So overall, it's pretty much all of us.
I mean, it's, in a way, with your background, with the work that you're doing, I'm assuming it has to be somewhat frustrating that more people don't get screened.
It's the hardest conversation that I have in my office is somebody who is 58, and next thing you know, they have a tumor on screening. And the family member sits next to the patient and says, well, you know, we know 50, because everybody's upset because now you're talking about cancer. I try not to go down those roads and say, listen, I'm happy you're here. We're going to do the best we can to take care of this particular problem. The only thing we could do is help that educate their family. So you can't change the diagnosis of cancer once it's there, but what you can do is use that as a tool to educate more people.
Now, you used a couple of different times the term polyp. Again, for us lay folks, what exactly is a polyp?
A polyp is where there's just some abnormal growth at a location in the colon. There are obviously some genetic mutations or things that happen that lead to the formation of polyps, but just simply put, it's an abnormal growth in the colon. Some of these polyps are more dangerous than others, but at the end of the day, we don't know exactly which polyp is going to become cancer. But what we do know is that over 95 to 98% of all cancer starts from a polyp. So we know we need to remove all of the polyps that we see. We never know exactly which ones are going to be cancerous. And again, that's also to simplify the discussion. That's the way I would leave it.
And typically speaking, is there a way to describe, again, I always try to do this from the standpoint of the layperson, how big are these typically?
They vary. They could be anywhere from a few millimeters in size to centimeters in size to actually wrapping around the entire lumen of the colon or the rectum.
Really?
Yeah. And so they vary in size greatly.
And then your treatment approach has got to be
Of course. It all depends on the location,
right,
where the tumor is located, because again, certain areas are have a much different effect on your quality of life depending on the location of treatment.
Right. Well, we're talking with Dr. Brett Ruffo. He's a board-certified colorectal surgeon, talking with us on our program on the Fan this Sunday morning. I mentioned earlier in our discussion, if you are on point and have a comment or thoughts along the lines of what we're talking about this morning in our discussion, you can join us toll-free, 877-337-6666. Let's go to Mike in West Springfield, Massachusetts. Mike, thanks for holding on so long. Welcome to the Fan.
Good morning. I want to chime in on this. Usually I'm talking about sports, but this is actually relevant to my life. My father died of cancer of the colon at the age of 72. I was 42 at the time. And I got some education at that point, enough to know, and I'm not trying to be overly graphic or sensationalize it, but it's to the point. When somebody experiences more than a couple of days of bright red on their bathroom tissue, not to automatically assume it's hemorrhoids, that you go and you get checked. And because of that checkup and the sigmoidoscopy and the colonoscopy, indeed, a couple of small polyps called tubular adenomas, the most, a small benign thing, were removed from my body at the age of 42. Had I waited till the typical encouragement of men to get checked at 50, it would have perhaps grown to a size in those ensuing years that would have made it be perhaps a more life-threatening situation. And with that experience, I've encouraged my nephews to get their first check at the age of 40 rather than 50, and to tell their doctors and their insurance company that this is out of medical necessity because there's family history. So, again, thank you for being on the show and adding your voice to that.
Mike, thank you for your call this morning. Dr. Ruffo?
I think he brings up a very valuable point. Besides the family history, which certainly, I got to be honest with you, when someone tells me they have a family history of colon cancer, I recommend a colonoscopy whenever they're ready. And again, like I said, there are some things that are outside the actual, what are you going to say, what's the standard? I think you go by what your gut tells you. But one point he did bring up that was interesting is having bright red blood. Blood from the anus or the rectum or the colon is not always from hemorrhoids. I think that's such a great comment that I want to echo. And again, because of that, I never tailor. My examination for every single patient with rectal bleeding is exactly the same because of what he just said. And this way, you make sure that everybody gets the same examination, and you don't just assume that a simple symptom of a little bright red blood on the paper just simply means hemorrhoid. So that's a great point.
We're in discussion on the topic of colorectal cancer awareness this month of March, Colorectal Cancer Awareness Month nationally. Dr. Brett Ruffo, who is a board-certified colorectal surgeon affiliated with Peconic Bay Medical Center on the island, is talking with us on our program. We're having a frank discussion. We've covered a lot of different areas. We also are trying to work in some thoughts from some of the people who are listening to our discussion. We're in the home stretch of our program, but before we go back to the phone, let me just touch on one thing with you, because somebody called who didn't want to go on the air and asked a question about polyps. The question, as I understand, is what's the percentage, if we can phrase it that way, of polyps that become cancerous?
I think the number is roughly, but I should say it more like this: it's about 5 to 7% have the potential to develop into cancer. Now, that being, and one of the calls mentioned before, tubular adenoma, there's a whole slew of different types of polyps, which again we're trying not to get into, because each one is a discussion in themselves. But about 5 to 7%. The problem is that we don't know exactly which ones will become cancerous, so we need to remove them, evaluate them through pathology, and that's really the only way to get a definitive answer.
Okay, we're going to, before we are done, to talk about some other screening tools than the ones that we have talked about thus far in our discussion. I know a lot of people who are listening to our discussion today probably want to jump in with some thoughts. Let's go back to the phones. Toll-free, 877-337-6666. We'll go to Fred in Marlboro, New Jersey, who's been waiting forever. Fred, thanks for being so patient. Welcome to the fan.
Go on, Bob.
Good morning.
Good morning, Doc. I'm in my 50s, and I had my colon ruptured when I was in my 30s. And I never felt no symptoms after that. And I just went for my colonoscopy. And they did find 2 polyps. And you were talking about size, and mine were like 10 millimeters and 12 millimeters in my colon and my rectum. So, I advise everyone, that are in our 50s to go check, because they took them out and they were that tube that you just said, that kind of cancer.
Sure.
And if I didn't go, they could, like you said, percentages that they would have turned cancerous. And I think this is a very good subject. And, they took them out, and I'm feeling healthy now. And it was only a 25-minute procedure. And you don't even know that it's done. Mm-hmm. So it's not like you're in pain, or, you know what I mean? It's a simple procedure. And I advise all men over 50 to get them done. And I have to go back after 3 years, because after the biopsies came back. So this is a very good subject. I'm just glad that you had it on this morning.
Thank you, Fred, and continued good health to you. Thank you for being so patient on the phone, too.
No problem.
Ready? Dr. Ruffo?
Again, the best thing about that phone call is we don't have to worry about whether those polyps will become cancer or not, because they're out.
Right.
And you don't know, could he have lived with these polyps forever and they never became cancer? Sure, but there's a good chance that they may have changed over time. We don't know, but what we do know is those 2 polyps are not going to give him any trouble. So I think that's a pretty impressive. That's the whole point of what we're trying to do here.
I mentioned earlier that we want to talk as well about some other screening tools that there are. What else is there that's available?
At some different ages, and there are some different modalities that are still accepted by some of the guidelines. Whether it be flexible sigmoidoscopy, which is like a colonoscopy, but it goes up a little bit less in the colon, and that could be repeated every 5 years. There's stool blood tests.
But the newer blood tests are something we use at Peconic Bay. I participate in a cancer services program where we just provide screening for certain patients that don't have insurance, and they use a test called the FIT kit. Which, and again, there's a couple of different types, but the bottom line is some of these stool tests are becoming more specific for lower GI bleeding, and that helps us provide screening on more of a high risk patient population. The one downside to some of these stool tests for blood are that they're mainly looking for cancer. Colonoscopy is looking for both, polyps and/or cancer. So some of these newer tests can say that some of the advanced polyps they are picking up, but the bottom line is that those tests are simply more or less looking for cancer, which is the advantage to colonoscopy. Some of the other screening parameters we have are something called a barium enema, and that's where you get some contrast placed in through the rectum, and we take a bunch of pictures with a radiologist. CT colonoscopy, CT colonography, virtual colonoscopy, whichever you want to call it. That's seems to be in the forefront because it's new. It sounds exciting. I only have to get a CAT scan. But what a lot of people don't understand is you still have to have a bowel preparation. There's still a risk of bowel perforation. And if they see something on the CAT scan, you still need a colonoscopy. So I think it's a great test. It's a great utility, especially if somebody's fearful. If that's the only thing they're willing to do, great. At least we have a testing option for them. But you have to look at all sides of this. The fact is, if they do see anything in there that's indeterminate, they can't see, you need a colonoscopy anyway, so it's not therapeutic.
Dr. Brett Ruffo is talking with us on our program on The Fan this Sunday morning. We're talking about this topic of colorectal cancer awareness. And tell you what, let's jump back to folks on the phone. Let's see. We're toll-free at 877-337-6666. Next up, I believe, if I'm reading this correctly, I believe is Kate here in New York City. Kate, good morning. Welcome to The Fan.
Good morning. Thank you. I wish people would talk about the test a little bit more. I was terrified to take it, just the regular colonoscopy. It is absolutely nothing. It's a piece of cake. But I wish they would be more graphic. You just simply the day before, you don't eat, you drink this stuff, you have diarrhea. So what? You just do that. And the next day, try to be the first one to make the appointment. And they give you a little Demerol or whatever. You don't feel anything, and you're out of there in 20 minutes.
She may have said the most important thing of the day.
I tell you, but they don't go into the test. And before I had my first one, and I'm pretty long in the tooth, and I was terrified. I had to lie down on the floor when the doctor told me.
Kate, I appreciate you breaking this down for us. Hopefully, maybe your words will help spur some people
Great.
to take a preventive approach. Thank you very much.
But I agree. She brings up a great point. That, and we didn't talk about that. She brings up a very good point. I mean, the test is relatively overall simple. The bowel preparation obviously is not any fun. But
that's the thing that gets so many people is that's where they get hung up.
But the thing is, listen. I've had mine done. What are you going to do? I think sometimes you have to look at yourself and say, "This is why I'm doing it. There's a purpose." The hardest part for me was not eating, watching my kid run around with food and double fisting running through the house. So I hid in the basement so he couldn't eat. But she's right, because the bowel preparation is not fun. But the procedure itself, we use a twilight anesthesia. People take a nap and they wake up and it's done. So it's much less horrifying than people give it credit for. So I think the test. Thank you for reminding us to talk about that.
Okay. There's other areas where I want to go in our discussion. One of them is in this whole idea of trying to lower the risk of colorectal cancer. And I always ask about this because I'm curious, not just the role of exercise, but what about the role of diet? Is anything pointing positively in that direction?
Well, activity has absolutely been shown to diminish the incidence of colorectal cancer. Obesity is an adverse risk factor. We know that for sure. Obviously, the diet, the Western diet, is not great, but we do know that. But activity, absolutely. Obesity certainly is a negative risk factor. So we do have to talk about these things. The other thing is high fiber diet used to get a big push that was going to diminish the incidence of colorectal cancer. Do we know that for sure?
not necessarily in the data, but what we do know is that a high fiber diet's healthy for a lot of other reasons as well, including cholesterol and diabetes. So it's a great diet. It's great for the colon. So I do think activity high fiber diet is certainly a great habits to get into.
What about consumption of alcohol?
Alcohol, smoking, these are just well-known risk factors for lots of cancers. It's hard to, when it comes to smoking, I don't really think there's much to say about it. We know the dangers. Alcohol, absolutely, poor risk, a pretty significant risk factor, as well as other patients with, like I said, other types of diseases that we really didn't want to go into. But for the average person, smoking, obesity, drinking, these are some risk factors that we can easily modify and help decrease our own incidence.
Very interesting discussion with Dr. Brett Ruffo on our program on The Fan this Sunday morning. Sports Edge follows our 8 o'clock update. Let's go back to the phone. Let's see. Dove, where are we headed next? I'm a little confused here on the screen. Are we going to okay, let's head first to Terry on Staten Island. Terry's been holding for some time. Terry, good morning. Thanks for holding on so long. Welcome to The Fan.
Yeah, good morning, gentlemen. How you doing?
Good morning. Good.
I was sick for 19 months with, crippled with flu symptoms. Took all sorts of tests. Nobody knew what was going on. Full body scans. At the end, I was diagnosed with Still's disease. And then what it was colon cancer.
So you were misdiagnosed, in other words.
Yeah, I was taking every test in the world, and I was getting sick twice a week, and nobody could find out what it was. And then, what happened was I found, the red tissues, and then they found out what it was. But it was just a nightmare, But what I did was I kept going to the doctors, and that was the thing to do, and get second opinions.
Mm-hmm. And how is your health today?
It's great. I got 3 years clean.
Good for you. Good for you. Continued good health to you. We're going to run here because we're a little tight on time. Thank you for being so patient on the phone and your comments this morning, Terry.
As a doctor, it's hard to, that's a conversation you'd like to have with him and have a conversation and go over all the details. But certainly there isn't any perfect situation for diagnosing cancer, and people do have to understand that CAT scan is not the test of choice to look for a colon tumor. And it's very different than a virtual colonoscopy. So I just wanted to keep that in mind.
Okay, we'll do one more call here. Let's go to Paul in Plainview on the island. Paul, good morning. We got just a short amount of time, unfortunately. Thanks for holding on. Welcome to The Fan.
Good morning. How are you today, gentlemen? My question is, I had colonoscopy done at the age of 52. They had found 3 polyps, which they removed, and they were benign. And I have to go for a follow-up in 3 years, which now I'm 55. And in October, I will definitely go for that follow-up. Years ago, they had said the standard rule of thumb was every 5 years you were allowed to go for a colonoscopy. Now they had changed it to every 10 years. Being that this is the number 2 cause of death or cancer is colon disease, why have they changed it to 10 years, and who decides that one should go every 10 years if you're clean?
All right, I'm going to let Dr. Ruffo respond. We're tight on time. Thanks for your call this morning, Paul.
The 10 years came from somebody who had a completely normal colonoscopy without any polyps or any type of pathology. Again, like I tried to say earlier, every doctor performing colonoscopy has a different follow-up, and when it comes to polyps, you need to know what the pathology of those polyps are to really dictate your follow-ups. And I do think it's an individualized practice, but the standard of care, if you read the task force, that's what it says. I didn't say I agree with it, but that's what it is.
Dr. Brett Ruffo, board-certified colorectal surgeon affiliated with Peconic Bay Medical Center. Thank you very much for joining us.
Thank you very much.
Very interesting discussion. Hopefully, the words shared today can be helpful for some of the people listening to us as well. Thank you for your input on the part of people listening to our program this morning.